CUNY Institute for Health Equity, documents and addresses structural inequities and advocates for the promotion of health and well-being in New York City. Nika Lunn is the program director of the CUNY Institute for Health Equity, and she's here with us today. It's a pleasure having you on the program.
Thank you so much.
I want to find out what this does. What is the Institute, and what is it that you actually do?
So as New Yorkers, we live in one of the wealthiest and most prestigious cities in the world. However, in this city are pockets of poverty, of limited access to healthcare, of lack of access to food. And in order to address these barriers to healthcare, these structural inequities, we do research and we help with community-based organizations. After we conduct the research, we distribute it to the appropriate sources in order to create change.
I teach a course on health equity and social justice to master's level public health students. And the three issues, I say, if you go away with nothing else, the three things that I want you to understand with respect to the social determinants of health that are the most powerful determinants, as we see in the literature and in the work that we've been doing, is race, poverty, and policy. We're relatively young in CUNY. We're about 4 years. And in that time, we've done a couple things. And one of the things that we focused on was really very much looking at the issue of the health of Latino men.
It's important to focus on minority people, both male and female, black, Hispanic, right? Poor whites, right? Individuals whose voices are not included. They're incapable of having their voices included.
The fact that they're focusing on Latino men is very important because there's probably very little to none, depending on the sector that you're talking about. There are programs that are addressing young men, which is great, but it's not really focusing on the Latino man.
There are many different factors that impact the health of Latino men and men of color in general. And it's only until we increase that awareness on a societal level that we can actually end up doing something about it.
My name is Ernesto Vázquez de Laila. I'm pleased to say my name as it sounds in Spanish because I live in Ireland now and I need to say Ernesto Vázquez de la Guila to be understood. I'm a medical anthropologist and I'm very happy to be here. We were very keen to show the plurality of the Latino Hispanic population and trying to avoid reification. You see in this work, trying to avoid the objectivation of the Latino population because sometimes with the good intentions when we say that we are incorporating a cultural approach, that we have a program that is cultural sensitive, but sometimes this program, what it's doing is reinforcing stereotypes because we have the illusion that we know how the Mexicans are, we know how the Brazilians are, and we're trying to show that there is a fluidity, there is a plurality, and different ways to be Latino in the US, and also different ways to be man. As a person from Latin America, something that shocked us when we are studying in the US is how important race is in everything in this country. It's a very powerful variable, something that is a hidden variable in Latin America. We have the French approach, so we ignore race. It's a taboo, we don't ask race because we are all citizens. But however, in the US, social class is a neglected variable. So that's something that we are trying to show here, how poverty was so powerful. So that when people are saying they didn't have access to health, it wasn't just about language barrier, but they didn't have money, basically. basically we're looking at what people do when they have a health program, what they do. The first thing is postponing the symptoms. What we found in the stories is that health was a luxury for many of them. As this man says, we just can't get sick all the time. Who will take care of the family if we get sick? For some of these men, when they tell you, I'm a macho, I'm a machista, means a man who is protecting the family, the provider, basically, of the family. So if we can transform this responsible man, the responsible man is not the one who neglects or tolerates pain, but is the man who looks after his health and who looks after the health of others.
I think Latino men and men of color in general, so far, right now, they are almost an unknown and unrecognized group that is in trouble. This particular Latino men, if we talk about graduation rates from high school and college, they're dismal. And so to understand how to change that trajectory, which will then increase the health, because we know some of the social determinants of health overall are poverty and education can take you out of poverty, and therefore we need to change the direction and improve the education that will then lead to improved health outcomes overall for Latino men.
Juan, Jorge, and Hector, 3 friends. Juan actually is a patient of mine. He's 23 years old. He asked actually at the time that we were talking, could I bring a friend? And so I said, sure, and that was Hector. Jorge, actually, I didn't know he was coming in. Juan said, I was hoping that Jorge could see you today. Hector finally came in, so I saw Hector. He's in the same boat as Juan, multiple partners. He ended up having HPV condyloma, and then yesterday his test for chlamydia came back positive. So a whole host, but Juan was the one that connected with him to get him into our services, and I think they're now all 3, in a sense, connected to us so that they can come back for future visits. I think connecting and engaging the trust of Latino men is an incredibly important activity that we should think about. We should train our providers overall to care for the whole person, and not particularly young men of color, but it's not focused on STD. I think the conversations I have that start off about sexual health delve into relationships, delve into so many things that young men have no opportunity to sort of disclose and talk about. We need to acknowledge the pressures of masculinities and move fluidly past them, particularly in our individual interactions. And including sexual and reproductive health as an initial entree into the lives of our young men is a really important way to go about it. Thank you.
Part of what we have to do in terms of educating our communities is let them know that there are things that they know about their bodies that maybe doctors don't. But there are things that doctors know about them that maybe they don't. So it's a lot more complicated than simply saying we have to get rid of the barriers, eliminate the disparities.
This is an overdose, over-drug society. So when you say Latinos resist, we should all resist, because what people call unnecessary here is a business model that pushes drugs, and a lot of physicians became what I call drug pushers. Come here, you get a drug, and the patient's now convinced that they should do the same. There's another issue, is how to deal with complementary medicine, which is not necessarily good if you mix this with the skepticism about Western medicine. This is another ballgame.
So nice to meet you all. I'm going to try to get to this very, very quickly because I do have quite a bit on this PowerPoint presentation. As has been said, I teach up at Columbia. The thing that I like doing the most is working with young men. Overall, the health status of Americans we know has improved, right? And life expectancy has increased. But on average, a man's journey on this planet, we're going to be here 6 years less. My thing was with my father dying young, and with a son who is in his early 20s, I want things to be better, and it's not right that we're living 5 years less. Even when they do go, we know that teachable moments are lost. You know, I'm a social worker, and I'm the biggest critic of my own profession. Well, how come we don't ask more about sexual issues, for example, when we're talking about why do I fight with my girlfriend a lot, or how come I can't get a job? Why doesn't that become part of the psychosocial history, where you ask for 1 minute, Would you mind if I ask you a couple of other questions? I ask this of all my clients, all my patients. It's about your health. It's an important part of health, sexual health. Have you ever had sex? When's the last time you had sex? Oh, thank you for telling me that. Tell me about your partners. Are they men, women, or are they both? Do you ever use protection? You know, what's your idea about becoming a I could take a sexual history in a minute, and we're blowing teachable moments. And we know that from the data. We're not doing a good enough job. We train our staff with what we call micro skills, and here's one. So normalizing, we train our staff when a guy says, I didn't know there was so much salt in prepared food, to respond, you're not alone. Most guys haven't heard that. Selective attention. I picked up some condoms, but I haven't used them yet, they say to Dr. Bell. His response would be things, but you picked it up. That's a great start. You get it? The whole idea is an assets-based, positive way of talking to them. Joining forces. I think my boyfriend Jose is going to be upset. I don't know how to tell him I don't want to be with him anymore. This is tough. Let's see if we together can think of ways to talk. Einstein said the most important thing is the universe friendly, and we believe the same thing about clinics and other places that men go. Bobby Kennedy said, there are those who look at things the way they are and ask why. I dream things never were and ask why not. I say, please, can we create more male-friendly spaces to talk?
Who gets suspected, who gets stopped, who gets questioned, who gets frisked, who gets arrested, who gets charged, who's convicted, and who's sentenced in prison. In today's America, are all points in a continuum of criminal justice policies, and each of the points I just mentioned to you has a racially skewed outcome. The disconnect between drug use in America being a function, actually, very well prevalent in the white communities, and the fact that most people get busted for drug possession, black or Latino, exists in virtually every urban part of America. Mass incarceration, the punishment industry, has this incredible effect on very, very localized communities. When I was working on a case that lasted about 8 years to challenge New York State's felon disenfranchisement law, the same policy that I just talked about, taking away the right to vote from people who commit a felony. And I was able to try to line up a handful of experts. One of the people I was talking to at first, and I started reading some of his writings, was a professor named Drucker, Ernest Drucker, who started talking about trying to quantify from an epidemic viewpoint, from an incident of public health viewpoint, what we now know is mass incarceration. So what we started doing is started analyzing from what he called years of lost lives. Metrics that demonstrate the number of people who get arrested, incarcerated, and literally taken out of their communities for these crimes, and then taken away and completely separated. And when you start calculating that based on the number of people, the years of lost lives, based on Rockefeller drug law activity alone, amount to 200,000 deaths. Collectively, we allow the criminal justice system to do this because we think it protects us. But then again, that goes part and parcel of how we do laws in America. We govern mostly through crime. And we do punishment very well in the United States. We happen to live in a city that is the arrest capital of the world for marijuana. Presided by a mayor who said once when he ran for office, yeah, I smoked it, yes, I inhaled it, and I liked it. The hypocrisy that exists by individuals who run a massive arrest function of things they've done when they were younger but didn't get busted for it is outrageous. The consequences of these convictions are significant. Just men alone, the rate of incarceration in the United States is about 1,822 at 100,000 people. And the rate of incarceration for whites is about 702 out of every 100,000 people. So the challenges we have is to think about the issue of public health from a perspective of mass incarceration in a very localized setting with very clear impacts to our communities. That the health consequences not only exist when you're inside the system, and those are significant, but also follow you when you're outside the system. Because a record will make it less likely that you can get a job, less likely that you'll vote, and therefore also correlated with lower healthcare indicators. Thanks.
What we do know is that we have huge, large numbers of Hispanic people being deported. We know that they're being put into detention centers. And many of those detention centers are privately run, right? And that funding for issues such as health care is not a concern. You're put in a holding tank, you can stay there for years until you're processed, put on a plane, and dropped off somewhere. Let's put on our list a policy program recommendation dealing with the issue of deportation. What recommendation can we make in relationship to the deportation of Latino men, right? They're being held in these detention centers for long periods of time. What recommendation can we make?
I have a hard time with that because, you know, in New York State, detention centers aren't, I don't think, are that big of an issue. I don't think. The real issue for the undocumented in New York State that are involved in the criminal justice system that I feel is more relevant is, in addition to all the other stuff they have to deal with, when they come out of prison or jail, to think that they can't come forward, like, for example, to a health care. If you go to a federally qualified community health center, you're not allowed to ask about your immigration status. But many guys will not come to the center because nobody has worked with them to get them over that fear. So they stay away. They stay away from, like Helen Atkinson. They stay away from the Ryan Health Center. They stay away from Betances down in the east, where my daughter's a nurse practitioner student there. And it's a shame because they're not getting health care. They could have gotten health care for free or for $10. One more barrier to them getting health care is their fear that they're going to be deported.
But realistically, what can the Institute do? You don't want to have, you know, we can't reform health care from the Institute. You know, and also, what's the benefit of that? You have funders that you have to also answer to. You have a university that you're a part of, the university system. So what realistically can you do? So,
in some ways, you know, what we're trying to do here may be even more practical than what they're trying to do, because their stuff depends on funding, depends on getting politicians to agree, whereas the kinds of things that we came up with here, which is the idea of getting people to see that all of our problems can be interpreted as a question of the criminalization of this community, right? Something that simply requires people to change their mind.
Increased diversity of service providing teams, right? So there's a lot of conversation about the need for service providers to look like the population. Not that those who do not look like the population couldn't provide services, but we need some cultural diversity. Advocacy around possibly voting rights, right? If we can empower the community, right, via empowering the formerly incarcerated, getting the voting rights back, but larger than that, as it was pointed out by a member of our group, educating the community about the need to vote. We had conversation about deportation, very important point for the Hispanic community. Many members of the Hispanic community being deported, what's happening within those facilities. So educate the population around their rights. Not just around deportation, but you have undocumented persons in the community who may be afraid to seek out medical care from fear that if they seek out medical care and they're undocumented, they could be arrested and then involved with the criminal justice system.
I think one of the most important things that the Institute could do is start framing the issue of what's Latinos' health, Latino men's health. Framing, if we talk a little bit about that, it's very common in social movements. We talk about how global warming has changed to climate change. You remember the ACT UP movement, they framed the AIDS issue. Instead of people dying with HIV, they had people living with HIV, and so forth and so on. So the idea is, how do we frame Latinos' men's health in this country? And the frame should only say not only what's our goal, but what is our action, right? It can encompass advocacy, it can encompass research, and so forth and so on. And this frame, hopefully with enough input, will be the one leading the country in many areas, not only working within the walls of CUNY, but also providing a framework for foundations, for the National Institutes of Health, for HRSA, to do research on Latinos' mental health. A piece that we spend a lot of time talking is about the link between health and education. And we're not talking about imparting information about health. We're talking about how important is the educational system for individuals in the society to accomplish health. And one of the problems that we have is that we as Latinos have the worst educational outcomes in the country. So what can we do that? For that, once there's a strategy to link the Institute of CUNY with educators engaging with the educational system from elementary school all the way to college, in which we create a dialogue, a training, and resources to train educators to make the system a little bit more culturally appropriate, if you will, to work with Latinos and with youth, and to think about and encourage strategies that are engaging and keep youth in schools. Along those lines, we talk about creating a CUNY University-wide course or series of courses around Latino men or Latino men's health. It can be in the context of public health, in the context of social work, in the context of geography or anthropology or international studies, but something that cross disciplines for students and faculty to bring this knowledge together. And last but not the least, we want to see how it's becoming us. We want to. We propose a conference on Latino or minority men's health that brings different sectors together. Brings not only academic, educators, community-based organizations, but community members and men themselves to learn, to dialogue, and to create actions to work around Latino men's health.
We kind of came up with the idea that what is happening is something that we call the criminalization, the culture of criminalization, that Latino males have become increasingly criminalized by the society in many different kinds of dimensions, not just simply in terms of being arrested, but in the schools because there's increasing surveillance, increasing security. Now the kinds of infractions that in the past would have incurred a kind of disciplining by principals now gets sent to the courts. People end up with JD, records as a result of punching another kid in the face, because now there's police that are present in the schools. So that to us suggested that maybe it's the criminal justice element that really should be the primary focus, or at least the notion of framing everything, health, education, housing, and occupational issues in terms of criminalization. And that this should be the framework, right? That there's been a criminalization culture that's been created for Latinos.
My question is, how might we as a society encourage these young black men who are victims of violence, and the data says they're victims of violence at rates higher than other groups, how might we get them to talk about their victimization and get them to seek out help for their victimization?
Guys will talk if you ask them. I have very poignant cases that have come my way. We can talk about it another time, but it is clearly an issue in male lives as well.
We teach our medical students to say, could you tell me more about what it was like on Rikers? Because I've heard from other people that it can be pretty rough, for example. And then when they tell the story, you say, thank you for teaching me that. Right? It sounds so simple, right? But that's what can be done. It should be done more. And I think what we have to figure out is how to take those common sense things and get them done more.
The issue of violence there's all this literature about structural violence. And what it basically is what you guys are talking about. Right. I am pissed off every time I read the literature on the incarceration issues that you brought up. I get pissed off every time I hear the exploitation of workers, right? And I get pissed off that people don't treat patients the way you guys do. So, I think the rage that you're talking about, I mean, I'm too small to really act on it. So, I can't, what am I going to do about it? But that range is structural. I mean, it manifests itself in beating up your girlfriend or your boyfriend, or it manifests itself in beating each other up, guys. But I am putting that whole issue of race of violence as the symptom of a very dysfunctional and pathological world in which Latino men live.
I've been most impressed with the knowledge base that the Institute was able to bring together. We have a great collection of academics, medical professionals that do hands-on work, and I was able to learn about a lot of innovative things that are happening in New York, and I think things that could be replicated outside of New York in terms of access to health care and involving people in their own healthcare decisions.
I think there are a lot of great ideas that have been generated. I think the challenge for them is going to be to narrow it down to what next.